Oh, thank you, Jens. Thank you, Jack. Thank you for the good words. Dankeschön, Jens, für die Vorstellung. It's a little bit late here already, so it's 8:30 in the evening. In the next 10 minutes, I want to share with you a new concept that I'm using since almost 10 years. It's called the 360 motion preservation. And this might be a good concept for Jens' yoga instructor. She's 56 and very elastic and has a spondy, and this might be the right technique for her. As we know, can you go for the next slide, please? Yeah, that degenerative disc disease is not only causing problems in the anterior part of the column with disc degeneration, circumferential tears, radial tears, disc narrowing, or spondylophyte formation. We also have in the same time facet joint degeneration with synovial reaction, capsular laxicity, subluxation, osteophyte formation, because we have this famous motion segment. This is a kind of tripod, and the anterior disc height loss is also affecting the posterior structures. Next slide. Ashley, can you go for the next? Yeah. So far we have developed a more or less black and white view on the treatment, surgical treatment. Either we do the decompression or we do the fusion or both of those. But in the meantime, we have a third option to offer. Surgical procedures for fusions are the old techniques, posterolateral fusion, uninstrumented, instrumented. We know the PLIF, the T-leaf, the A-leaf, X-leaf, and the 360 fusion. If we go to the next slide, then the problem with fusions, any kind, is that we have developed a new disease, what we call the transition zone syndrome of fusion disease. That means a breakdown on the adjacent levels, because we are fixing a couple of levels, a single level, 2 levels, 3 levels, and we are forcing the free levels to take over the missing mobility of the fused areas when the patient, especially when the patient is sitting or flexing forward. Next slide. Can you go to the next slide, please? Yeah, the question is all the time when we started with motion preservation, do we have other options available? In the anterior compartment, we started with total disc replacements. The goals and objective of those have been to restore and maintain the motion and the spinal balance. That's very important, also the spinal balance. And we have seen now, or we see now after using these devices 20 years, that we will not accelerate adjacent level degeneration. We cannot stop it, but we will not accelerate the adjacent level degeneration, what we will do with fusion devices. And if we have to go to fusion, it does not preclude fusion. We can all the time go a step further if necessary. Next. Next slide, please. Yeah, the recommended indications, as has been pointed out before, is a single level application from L3 to S1. And recently also a double level application has been approved in the United States. Here's a case of a single level. You see an asymmetric degeneration of the L3-4 segment, leading to the beginning of a degenerative scoliosis. And by using an artificial disc device, you can rebalance the segment, you can remobilize it, and you allow the patient to find its own specific profile, as you can see here in the post-op slide of this specific patient. Next slide. Shows, next slide, please. Ashley, can you go for the next slide, please? Okay, so you see one slide back, please. You see the beauty of the case that I want to show you here is we want 2 slides back, please. Yes, one more. Yeah. You see, this is a classic example where you have potential. One slide forward, please.
You have control, Dr. B.
Yeah, it does not work. Maybe you can do, yeah. You see, this is a very good example that demonstrates the beauty of motion preservation and compared to fusion. We have a severe disc degeneration 4-5. The patient had a previous disc surgery there, and now we have a severe disc herniation 2-3 with a bladder dysfunction, with a mass herniation. We have a healthy segment at 3-4 and a healthy segment at L5-S1 and a degenerated disc at L1, L2. So what can you do with a fusion procedure? Probably the aggressive guys would fuse from L1 to S1 to avoid further floating fusion problems. But with disc arthroplasty, you fix only the levels that are affected without any problems on adjacent levels. And you see you have a wonderful mobility of the whole entire lumbar spine. The next level. The next slide, please. Yeah, and you see you have a full functional patient. Next slide shows expanded indication. This, of course, is not approved in the United States, but this is what we are doing nowadays. Most of the time, we're getting the tough patients. So what we see is the slide function does not work properly. Can you go back? Two more, one more, and one forward, please. So it's like in the old days when you had the regular slides and somebody had to press the button. Okay, you see here, you do it adjacent to a fusion. You can use it in multi-levels. We have done up to 5 levels, and you can do it also in slight degenerative scoliosis cases. On the posterior area, we have to control dynamic dystability. That can be hypomobility or hypermobility, and by having hypermobile facet joints, or we have already hypertrophic facet joints leading to a canal stenosis. Next slide, please. You see here the posterior dynamic devices. The first generation was the graft ligamentoplasty, the Scientix dampener, the Dynesis, that had been more elastic fusion devices and not real motion preserving devices or motion controlling devices. The true second generation devices that we are using, next slide please, is the posterior dynamic system. That is mimicking the real mobility. That means we have this traction and anterior position of the pedicle when the patient is flexing. We have a modularity of the system. We can use either rigid couplers or slotted couplers with motion couplers. And we can combine this as we like, very individual. This device is reducing hypermobility by about 30% back to normal mobility, as you can see here in the next example. Next slide, please. So you see this is a hypermobile case, and the DSS could control this quite well. So very important, as we know, is the balance between the anterior and posterior structures. That means also the ability of the patient to find the right lordosis in order not to get a flat back syndrome. And therefore, it's very important that we allow the patient to find its own motion pattern. Next slide, please. This is a case that shows the combination of arthroplasty and posterior dynamic devices. That is what we call 360 motion preservation. Next slide. Next slide, please. Yeah, you see here a 24 months, 49-year-old male patient and a 46-year-old female patient, where we have done, after doing a posterior decompression due to spinal stenosis, with 360 motion. Next slide. Next slide, please. Yeah, so what do you do now in complex cases? Tell them to live with it, to continue conservative treatment, decompression, any kind of fusion. Patients like this, this is a patient. You can go forward, please. Ashley, can you go forward, please? One slide. Yeah, this is a case that shows a clear problem at 3 levels. We have a slip, grade 2, with severe canal stenosis, as well as we have facet arthritis in the upper 2 levels with severe vertical segmental instabilities at L3-4 and L2-3. So what can you do in this case? Either do a fusion, a decompression at 3 levels, or you use the Coflex in this dynamic device. What I do not recommend, because we have already a slippage that's too far for the Coflex, and this is still a dynamic patient. She wants to go for golf and she wants to do a lot of traveling. So this case demonstrates a clear benefit for the 360 motion concept that we have started to use. Next slide. Next slide, please. Yeah, and you see here, this shows in the lowest level, we have done a fusion coupler within a 360 fusion, in opposite to the other 2 levels where we have used the 360 motion concept by using dynamic couplers and artificial discs in the front. The last case shows a 66-year-old male patient with canal stenosis at L2-3, 3-4, and the subarticular stenosis at 4-5, with retrolisthesis L5S1 and retrolisthesis 4-5 in the kind of vertical segmental instability, beginning scoliosis. So this is a kind of guy where most of the other colleagues would have chosen probably to do a long fusion construct in this case, either as an X-leaf or as an T-leaf procedure or a 360 A-leaf procedure. But I think this case shows the real challenging case, the usage of motion preservation that also allows the patient to maintain his function by using the 360 motion preservation concept, by using artificial discs. Please, next slide. You see here the MRI scan shows a clear stenosis at the 3-4 level, 4-5 subarticular at 2-3. Next level. Next slide, please. And by using the 360 motion concept, you can maintain all his mobility by doing also posterior decompression, because by using the DSS system, there is no real need to maintain the facet joints, because the system is taking over the function of the facet joints by avoiding or eliminating rotation by only 1 or 2 degrees, and allowing flexion and extension in almost a natural manner. And it works very well in co-function with, for instance, with the ProDisc device, with a single center of rotation device. Next slide. Next slide, please. So you see here that was 2 years post-op. Here's excellent outcome, is a clinical outcome. So in conclusion, we can say that with 360 motion hybrid constructs, we have an effective motion control. We can use the high corrective potential and maintenance of functionality. And the first results show a very good improvement of clinically relevant parameters combined with a high patient satisfaction. Of course, we have to do further investigation on larger cohorts to get a long-term results as well and to understand the optimal patient population. But so far, 360 motion hybrid constructs can be effectively used alternatively to fusion procedures, especially in multi-levels and complex cases. The next slide, please. So what remains for fusion, that's of please the next slide, is of course severe spondylolisthesis, real instabilities like fracture cases, infection tumors, deformities like scoliosis or kyphotic patients. These will be staying the maintain of fusion. But I think in degenerative disc disease on the long-term run, we will use more and more motion preservation. Thank you for your attention. Next slide. Can you go to the next slide? Yeah, thank you for your attention and keep on moving.
Thank you, Rudy. I saw that you cemented you cemented the screws in the multi-level construct typically. Is that what you're doing?
Yes, yes, because what we have seen, the big problem on any kind of posterior dynamic device is screw loosening, because we have a very unfavorable force application to the screw and the bone. And we see all the time the loosening was in the Genesis and all the other motion preserving devices also a problem. By using bone cement regularly, we could reduce this dramatically down to 5% approximately. But in co-function with the disc, we could even reduce this significantly lower to about 1%.
Rudy, the DSS looks a little stiff. It looks like the patients don't get a lot of flexion from the ProDisc in the front. Have you looked at that?
Yeah, if you measure it, it's enough motion. Okay, you will not get the same mobility like if you use the disc alone. But because we are removing a lot of posterior structures by doing significant decompression procedures, because these are the difficult cases, where you have stenosis, that you remove most of the facet joint. And the DSS allows you still in about 80% of the normal range of motion of a segment. So we have about 8 to 9 degrees of flexion and about 6 degrees extension. So altogether we have, I think we have enough mobility. So we have 14 degrees of mobility if you go flexion extension. So the ProDisc offers 20 degrees. Okay, it will be reduced a little bit, but if we use it in multi-levels, I think this is enough so that the patient still has a lot of flexibility and can adjust his spine also in a flat position and a more hyperlordotic position.
Thank you, Rudy. It's great to see you again.
Thank
Yeah,
you.
it's a pleasure on my side.
Especially for some of my American colleagues, it was almost exactly a year ago when I visited Dr. Bertagnoli and I witnessed almost the same exact surgery.
You're muted, Armin.
Oh.
Yeah.
Am I muted?
It's showing you muted.
Okay.
There you go.
I tried not to use the microphone on my computer because it reverberates. In any case, I was just asking questions to some of my American colleagues because I witnessed the surgery almost exactly a year ago when I was visiting Dr. Bertagnoli. And I come back and I wonder, is it kind of what Genesis did to the US market, kind of the bad taste in a way it put in everyone's mouth? Is this one of the big reasons why we can't even consider bringing technology like this to the US?
Well, maybe. Remember they made Genesis, they said either you have to do an IDE study or you can just be labeled as a fusion device. So they elected not to do a motion study. So you may be right that we don't have that ability anymore.
Yeah, I think this was the big problem because most of the studies has been done as fusion studies, and these devices are definitely not designed for fusion. And I think there was a time when FDA ask the questions, why do you use this for fusion and not a solid rod? And since that, I think all these studies have been skipped.
Yeah, it's just I find it tragic that, you know, again, this appears to be a wonderful technology that has, I believe, application in what we're trying to achieve here, which is preserving motion. And yet, you know, we're restricted in terms of its usage and even considering bringing it here. And I don't know what the commercial viability of this would be if you had to go through full ID study.
Yeah, I mean, it'd be 5 years and lots of millions of dollars, so
50 million.
not likely. All right, thank you, Rudy.